thanks everyone for coming. Nowadays we will start the meeting, and before Professor Bismuth we start the opening ceremony, there is the General Manager of Humanitas that is here to present the greetings of our institution that is hosting us for this nice event.
Welcome, everyone. It's a pleasure for us to host the International Symposium on Hepatobiliopancreatic Surgery here in Humanitas, and we are really glad to welcome Professor Henri Bismuth here. It's an honor to have you here today. And thanks also to Professor Guido Torzilli to organize here this meeting. At Humanitas, we strongly believe in quality, in clinical quality, and in quality of service for patients. Words such as outcome, readmission rate, patient experience are a common language for doctors, nurses, but also for all the staff involved in the organization. We treat every year with surgery, chemotherapy, and radiotherapy more than 7,000 patients with cancer disease. And cancer treatment represents more than 30% of revenues of our organization. So we know that to make quality and innovation, one point is crucial, is comparison, benchmark, sharing of ideas to understand where the borders are and how to overcome them. So today we have more than 50 surgeons here, more than 50 companions coming from all over the world with this goal, understanding borders and how to overcome them. So just a few words, thank you to being here, and I wish you, in Italian, buon lavoro.
Grazie Riccardo, thank you very much to Dr. Bui. And I ask Professor Bismuth to start the opening ceremony.
Mr. Director, dear colleagues, dear compagnons, our superb organizer, Guido, gave a name to our meeting, When Innovation Meets Tradition. So I would like to start by innovation. And for that, I have the idea to go to the metaverse in order to find my avatar. I asked the technician, I hope he will succeed to open the cloud and to find my avatar. I know him, I speak with him. He will introduce the compagnon, I hope. He speaks in English and he has a problem with his tongue. He said that he wants to improve my English and to speak with the way the English are speaking with this kind of movement of the tongue, but I think it is too much, he exaggerates a little. Let me think easier. Yes. I introduce Henri. He's a very good speaker.
Many thanks, Henri. You have always the good word.
Okay.
It is a real pleasure to open now the second part of our meeting. Let me tell you, for those who don't know, what are the compagnons?
I know that, I will do it.
Please, Henri, don't interrupt me while I am speaking. Please, let me go on. The compagnons are a group of surgeons who train at Paul Brousse Hospital with me, and more recently all over the world, by the Compagnons themselves. I consider it as a family with son, daughter, and now grandson and granddaughter. The important thing is that they share the same spirit in the practice of surgery.
It's all very short.
You always say that I speak too much.
Okay, thank you, Henri Bey. Let me now continue to introduce the Compagnons. You see his house, a beautiful house with a sea on the, and you see the painting. It shows beautiful painting. Okay, thank you, Henri. And now I would like to introduce myself, the Compagnon, not him, and I will ask you to come with your name, please. The Compagnons are here. Some are not arrived yet, but anyway, I will give you. Eduardo Santibanez, please come, be in front, we take the photo. Eduardo Santibanez for Buenos Aires, Oscar Andriani for Buenos Aires, Rodolfo Rossi. No. All your applause until the end. In front. We take a photo. Then Fernando Alvarez for Cordoba, Valerio Lucidi, Bruxelles, Belgium. From Brazil, Antonio Calil, Porto Alegre, Carlos Eduardo Santos, Rio de Janeiro, Marcelo Linares, Sao Paulo. From Colombia, Juan Manuel Rico Juri from Cali. From Egypt, Rachad Al-Masri, please stop your photo from here. From France, Jean-Philippe Adam, Bordeaux, René Adam from Villejuif, Philippe Bachelier, Strasbourg, Laurent Chiche from Bordeaux, Marc-Johan Metz, Gina Crissat from Paris, Françoise Bonhomme, Villejuif. From Ireland, Oscar Trenor is not here yet. From Italy, Fulvio Calis, Gennaro Nuzzo from Roma, Fulvio Calis from Napoli, Riccardo Pellicci, Petra Ligure, Guido Torzilli, Milan, of course. From Japan, Katsumori Imai, Kamamoto. From Netherlands, Mark Bebelmans, Maastricht. From Poland, Krzysztof Jenewicz, from Warsaw. From Portugal, Eduardo Barroso, Lisbonne. Hugo Pinto Marques, Lisbonne. Ricardo Martin, Coimbra. Guilherme Traio, from Coimbra too. From Turkey, Ibrahim Astarcioglu, Izmir. Switzerland, Pierre-Alain Clavien, Zurich. Alexandra Cristodi, Lugano. Pietro Maino, also from Lugano. Christian Toso from Ginevra. United Kingdom, John Isaac from Birmingham. Please, John. From United States, Dimitri Alden, New York. Lee Gordon, Nashville, come. Tomoaki Kato is waiting the transplant in New York. Andreas Katz is coming, I hope. Jora Kua, New Jersey. And Nicolas Jean Voté from Houston. Thank you all of you. And please now, take the picture. All the Compagnons are here. Thank you for coming, all of you. Pietro. Thank you. And now we continue the welcome ceremony. Guido. Where is Guido? No, Guido. No, Guido, to give a talk.
Not just
Are you going to speak again? Or I come and begin?
you will start to the moderation. No, I just introduce. You want that I say something, that's all. But Eduardo, 1 minute, 30 seconds. So, Professor Bismuth recommended me to say something as a local organizer. I just want to thank all of you for coming. Also thank for all of you for the patience that you have had. And sorry if something is wrong or the organization was somehow troubling. more and more difficult to do this event in the actual times, but thank you to all of you and to the institution and also the venue, which helps a lot in terms of facilities. I'm really pleased to host you and to have all of you here. It's Compagnons is a great opportunity to have the 90% of the best surgery in HPB world together, which is uncommon, and they uncommon unless you are organizing a World Congress by the official societies. And having them spontaneously and very happy to be here is an additional element that make all of us excited to join and to follow the, I may say, the real pioneer of HPB surgery in the world, and he's the only person that was able to build an hospital on HPB once HPB was just an idea, more or less. And this hospital is still, when I visited it the first time, it's really a model for a modern hospital today. And then I was really impressed. And then it's my great pleasure to be honored to have the task to have hosted you here in Milano. And that's all. I don't want to, otherwise everyone is too emotional. And let's start. Professor Barroso.
Okay, let's go to begin our symposium. But I would like to say that I tell you, it's a big privilege to belong to this Compagnons Hepatobiliaires. And I must say to you that nothing in Lisbon was possible without the support of Professor Henri Bismuth. Our center in Lisbon is a real metastasis of the Poblu's idea from my older brother. And really, now I am retired, but I want to continue to come and meet every one of you, because this is our family, really. And please accept again our fantastic support that you have done to our center in Lisbon, that now Hugo is the director. Ricardo, it's a pleasure to be with you. So to begin, I give you to the world. Excuse me these simple words, but I needed to say that.
You said what I think everybody is thinking. So we start with our session. I want to call Christian Toso. Yeah. Okay. You just arrived. So you said.
So thank you very much, Mr. Bismuth, Guido. Very nice organization, so it's a pleasure to be here with you today. But a bit unusual, today I would like to discuss some basic science and not some clinical science, and look and explore with you the impact of porto-systemic shunting on HCC. Of course, we all know that the gut is connected to the liver, and this builds the so-called gut-liver axis. We also know that there are many bacteria in the bowel, and that in the presence of liver disease, both in mice and in humans, there is an increased leakiness of the bowel, releasing some bacterial products into the portal system. As a result, and here more present in patients with decompensated cirrhosis, you see more LPS endotoxin in the portal flow, increasing with the Child-Pugh score. And with that in mind, we can think that there is the potential to build a vicious circle. You have a chronic liver disease, this increases the portal pressure, alters the bowel, and increases the pro-inflammatory bacterial-derived product translocation into the portal system itself, impacting the liver and worsening the chronic liver disease. And all of that has the potential to have and to increase the risk of HCC. And this circle is also supported by previous data here from another group demonstrating that in mice, in a model of HCC induced by the injection of DEN, a toxic carcinogenic drug, with the addition of tetrachloride, you see that these mice, wild-type mice, develop HCCs. But when you perform the same treatment in mice that are TLF4 mutated, so with no potential for the LPS to link its receptor, the TLF4, you prevent the development of the HCC. And this shows that the LPS TLF4, the gut-liver axis, can be cut and prevent the HCC. It is also the case when you clean the bowel, less bacteria, by giving antibiotics, you prevent HCCs. When you use germ-free mice, you prevent HCCs. And vice versa, when you give LPS, you increase the risk of HCC in these mice. Some other data from our lab looked at the similar process, but this time not looking at de novo HCCs, but more at the potential for circulating HCC cells to engraft and grow in the liver. And again, we gave antibiotics, TLF4 antagonists, and we used TLF4 knockout mice. And we demonstrated it's the three last conditions that by cutting this axis, LPS TLF4 axis, again, preventing or cutting the gut-liver axis, you prevent the development, or more precisely, the engraftment and the growth of HCC cells in the liver in this specific model. So now the question is, now that we know, or we can assume that there is a vicious circle, the question is that, is there a way to cut and to prevent this vicious circle by performing a porto-systemic shunt, which would decrease the portal pressure and hopefully preserve the bowel, decrease the release of bacterial products in the portal system, and ultimately potentially preventing an ongoing insult to the liver and the chronic liver disease. The idea would be to preserve the liver itself, but also to prevent the HCC. For that, we used mouse models of HCC with or without shunting, and we monitored them up to 40 weeks. We looked at the development of HCC, and the two models were one, as stated earlier, a model of high-fat diet-fed mice injected with DEN, this carcinogenic drug, and the other model used lap-MYC mice, which are overexpressing the MYC oncogene and demonstrating an increase, or demonstrating the presence or the development of HCC in the presence of a choline-deficient diet. The porto-systemic shunting was performed by performing a small incision over the spleen. The spleen was taken out. We were making superficial scratches on the spleen, inducing a light bleeding. The spleen was positioned in a subcutaneous pouch. And with time, in fact, relatively quickly, over 2-3 weeks, you see when performing a CT scan on these mice, the development of a collateral vein in 85% of the mice. And we, of course, only use those that have a demonstrated shunt. With that, you can decrease the pressure in the portal system almost back to normal conditions. It's the CD control diet mice, and significantly lower than what we can see in the high-fat diet-fed mice, the dark blue mice, which show an increased portal vein level. This had an impact on the liver. Here, looking at the SAF score and looking at the histology of the liver and demonstrating a decreased level of steatosis in these mice. Of note, we were not able to see a decrease in the activity of the fibrosis stages. This may be related to the fact that these models do not develop much inflammation or fibrosis as a baseline. And this was also confirmed when assessing automatically the steatosis, again confirming a decreased level of steatosis in the liver. So shunting could prevent and decrease the insults to the liver. Now the question is, what is the effect on the HCC? And when you look at the human literature, there is no convincing data. Some papers say or state that there is an increased risk of HCC linked to the presence of a shunt, of a TIPS, for example, and some others state that it is a decreased risk in the presence of a TIPS. In these models, we have shown that with time, there was a decreased risk of developing HCC, so a decreased carcinogenesis, which was not much visible at 28 weeks, so we had to wait quite a long time, up to 36 weeks, to demonstrate a significant difference between the two groups, here in the DEN injected mice. But this could be reproduced, so it's solid data. We performed this specific experiment twice, and then we confirmed it also using the Laennec mice, also demonstrating in the presence of a shunt a decreased risk of developing HCCs. Now the question is, why is it so? We can assume that because the liver is healthier with less steatosis, it might be less at risk of developing an HCC. But we have also observed that in the presence of a shunt, the livers were showing less oxygen, almost back to the level of the control mice, and significantly with significantly lower levels than in the high-fat diet-fed mice without shunting. And it is known that HCCs are oxygen-avid tumors, and to confirm that even further, we perform another experiment using other animals with DEN and a shunt with or without the artery. So in some of the animals, we're cutting the hepatic artery, and you can see that at 28 weeks, there was not much difference in the number of HCCs between the mice, but at 36 weeks, we were seeing a significant difference with less HCC, less carcinogenesis in the absence of the arteries. So it matters, it makes a difference whether you have a high or a lower level of oxygen in these animals. So it has an impact on the carcinogenesis, the development of HCC. However, the surprise was that at the same time, also seeing a decreased number of HCCs, we're seeing an increased HCC growth. In these animals, we're performing repeated CT scans, and we measured each specific HCC and assessed the trend over time demonstrating the growth of these HCCs. And we demonstrated a significantly increased growth of the HCC in shunted animals. This is still something under exploration, but it could be linked to an increased inflammation in these livers. When performing microarrays in the livers, we could demonstrate a higher expression of various inflammatory genes for the S100A8, S100A9, both increase in the presence of an inflammation and known to be involved in liver disease and HCC. The same for the serum amyloid protein, also involved in HCC, and strangely, our friend, the TLF4. This was confirmed performing PCR testing in these livers, demonstrating similar differences. This is still under exploration, but it could be a way to explain the difference in the aggressiveness of the HCC and the increased aggressiveness in the presence of a shunt. But of course, all of that is mouse data, and we wanted to explore that also in human. And we therefore used and got access to the SRTR human database, which is a large which states and stands for the Scientific Register of Transplant Recipients. So it's a large US transplant registry. And we compared patients with and without TIPS and looked at the HCC growth and carcinogenesis for patients while they were on the waiting list. So we had access to multiple CT scan assessments while they were on the waiting list. As a reminder, there is more than 300,000 patients on that list, and we looked at the time period 85 to 22. We got access to a bit more than 2,400 patients with a TIPS, so it's patients with a Y for yes, and we compare them to patients without a TIPS, so 45,000 patients. And no surprise, there was striking difference between these two groups because patients with a TIPS had a more altered liver and they were more transplanted because of a decompensated liver cirrhosis, while they had lower and less and smaller HCCs. So as a consequence, we had to use a propensity score matching system based on age, gender, BMI, the cause of the underlying liver disease, but also the MELD score and the type of HCC treatment they received while on the waiting list. And at the end, we matched one patient with a TIPS with two patients without a TIPS, and we got similar baseline characteristics after matching between the two groups. And the interesting thing is that at the end, when looking at the behavior of the HCC, we have seen exactly the same setting and the same outcome and the same behavior as those observed in the mouse, with a decreased number of HCC over time in the presence of a TIPS. However, these HCCs tended to be more aggressive as they were growing more in the presence of a TIPS and showing higher levels of AFP. So overall, I understand this is still under progress. I understand this is still a bit weak, but it's interesting to see that both our mouse and human data are matching. When looking at the impact of shunting, they suggest a decreased risk of HCC carcinogenesis, may be linked to a decreased steatosis, may be linked to a decreased oxygen level in the liver, but at the same time, they show an increased HCC progression, may be linked to some higher degrees of inflammation. This is still to be confirmed, but it shows that maybe we should be a bit more careful when thinking of putting a TIPS in patients that are at higher risk or have already an established HCC in place. I would like to underline that this is the work performed by a large group, including Andrea Pelloso, MD PhD from Geneva, but currently in Pulbrook for a fellowship, and currently taken over by Sofia Elagi, MD PhD student in my lab at the present time. Thank you very much for your attention.
Can I ask to Jean-Pedro to come here? Yes?
So thank you, Christian, for the paper. You have pushed me to read a lot, and I found just few things. But so the paper is great, talking about the basic science, but it's trying to explain something that happened in the clinics. When in the liver you have some decrease of the flow of the portal vein, you have an increase of the artery. So my first question is the finding about of less oxygen in this model when we are expecting that we are decreasing the portal vein is increasing the artery and you have more oxygen. And this is explained clinically in some kind of patients. The patients that have congenital porto-cava shunts, this patient is showed that they have more HCC and they have more nodal hyperplasia. So, and this could be related to a promotion of the reproduction of the some kind of surge of cells related to some growth factors. So my question is about one of the topics here is about the oxygen, how you can explain, or is the rate of the flow that you are decreasing. But I think that the paper is very important because it's explaining something that happened in the clinics.
So first, it's I agree that it is probably, at least in part, linked to the oxygen level in the liver. The ratio between the portal flow and the artery flow in the mouse is more in favor of the porta in the mouse. So this might explain why we can see this effect more present here in the mouse than in a human. Also, it's difficult because when you do a surgery and you clamp the portal vein, for example, and you look at the difference in the level of oxygen, it's difficult to see this effect, the hepatic artery buffer effect on the short course, because you can do it only for a few minutes. And of course, these effects we have been seeing were established over months. So it's extremely difficult to guess what's happening a few months later by performing assessments in the OR. So of course, as always, mice are not humans, so it's difficult to replicate it to be sure that they are really matching what is happening in humans. But on the other side, we do not have really good tools to assess that. We are currently getting access also to liver samples of patients that have undergone TIPS, had an HCC, and looking also at microarrays, both of the HCCs and of the underlying liver, to see whether we can see patterns that can match what we see in the mice, which is, I think, going to be very interesting. Yeah.
Okay. Christian, I have two questions. One, did you check the patency of the portocabal shunt in your animal? In my, it was my MD thesis on portocabal shunt on the rat, not on the mouse, on the rat. What I observed is that in some animals, they block the thrombose, the portocabal shunt, and the effect is totally nil. That means it depends the percentage of animal that you have, and you have to take care of this before exploiting the results. So my first question is that. The second question is about the type of portocabal shunt. Is it a end-to-side or side-to-side portocabal shunt? As you know, side-to-side is contraindicated for there is an aspiration of the portal blood with a thrombus of the tumor going fastly in the extremity of the portal vein and going even to block the shunt. But you know that in humans. So on your experimental work, what was one, if you check the patency of the shunt, and two, what type of portocabal shunt are you doing?
So unfortunately, we do not have your skills. So we were not performing surgical shunts, putting two vessels together, but we were using the trick I showed, with the spleen that we're scratching and putting in a subcutaneous pocket. And this had been described in the past as an efficient way to build a shunt. Of course, we were a bit not sure about the effects, but we took care of, one, measuring the difference in the pressure. I showed that. Second, we injected beads into the ileocholic vein to see the part which is going to the portal vein and the part going to the shunt, and we have shown the patency with about 1/3 of the flow going to the shunt and not to the liver. And in all the animals we have used, we performed a CT scan to make sure that the shunt was patent, and at the time of sacrifice, we were in the subcutaneous, we were seeing the vein just to confirm. And again, the shunts were patent, visible, and stable in 85% of the mice, and we only used these mice. So in the 15% without a visible, documented shunt, we didn't use them for the experiment.
But as you know, the technique of direct portocabal shunt in the mouse exists already. It's more difficult, of course, but it is possible by microsurgery to do it.
Yes, but more challenging, and we needed something more established.
I agree.
So there is a time for another short question. No? No. It's okay. We can close. Thank you very much.
Well, let's pass for the Oscar, Andriani, and after the discussion of Guido Torzilli, liver resection based on Laennec's capsule for cranial approach of hepatic veins. Please.
Thank you, Eduardo.
Oscar.
Well, thank you, Guido, for organizing this meeting. And I want also to be grateful with Professor Bismuth that gives the opportunity to share and to gather every year in not only scientific exchange, but also friendship from all over the world. So I begin with some anatomical facts. In 1640, Johannes Valles from Leiden described a tunica covering the portal triad going within the liver, accompanying this arteria, portal vein, and artery, portal vein, and bile ducts. A few years after, you all know Francis Gleason, who described perfectly and precisely in casts, describing in Anatomia Hepatis, a famous book, the same sheet, and was during a lot of years recognized as the only sheet of the liver. But in 1802, René Laennec describes another sheet that is less connective and involves not only surround not only vessels but also some viscera. In this particular case, liver. So in this scheme, you can see in green the Gleason sheet that is covering and surrounding the portal triad and going within the liver, accompanying these elements. But in red, you have the Laennec capsule that surrounds not only the liver, the retrohepatic inferior vena cava, and also the portal triad within the liver in the distribution, as well as the Arancius ligament and the round ligament. And you can see the difference between a Gleasonian pedicle and the hepatic vein, which is not covered with the Gleasonian sheet. There is also some communications between the pedicles from the portal triad and the hepatic veins, and you can see how it is easy to detach this Laennec capsule that in some way we can say that acts as a barrier between the tumor and the vessels. Concerning the approach, the classical approach to the portal veins is from the caudal to the cephalic portion. It means opening the liver and going from down to the top. And you can see here, for example, how the hepatotomy begins from the lesser part of the liver. We used a pedicular clamping and the clamping of the hepatic veins in order to work in a bloodless field. And this is the result. You can see here the inferior vena cava, the right hepatic vein, the middle hepatic vein, and a portal pedicule in the bed of the resection. Claude Quinault described also two different approaches. The first one is the extrafascial approach, which is the more common, and the other one is the intrafascial approach. For the intrafascial approach, the extrafascial approach, sorry, you have to dissect the connective tissue surrounding the confluence of the hepatic veins, and we can see here the lamina of the cardiac part of the Laennec capsule. So we can have an extrafascial approach. The intrafascial approach, we have to open slightly the cranial part of the liver, going from the top to the caudal part. And for that, I will show you this case about a single liver metastasis. The primary was resected in 2019. At that time, the patient was treated in another center and was considered unresectable for the liver. She began capecitabine and oxaliplatin, but she needed to stop due to toxicity. She had in 2 years a mild progression, but only in the size of the lesion, but it was only this lesion. You can see here the relationships between the inferior vena cava, the hepatic veins, and the portal triad. In this coronal CT scan, you will see the right hepatic vein, the right pedicle, and the middle hepatic vein at the tumor, very close to the inferior vena cava. So for the surgical planning, first of all, we planned to mobilize the right hemiliver, encircling the right hepatic vein, then mobilization of the left lobe and the Spiegel lobe, ligation of the inferior right hepatic vein, and ligation of Spiegelian veins for the detachment of the paracaval portion of the caudate lobe, and then encircling the middle hepatic vein, as you see in the scheme. And then the cephalic approach of the Laennec capsule. This is intraoperative ultrasonography, the inferior vena cava, the middle hepatic vein, several branches from the left hepatic vein. This is a sagittal view. We begin with the detachment of the falciform ligament and the coronary ligament in order to access to the right hepatic vein. The right hemiliver was already mobilized. This is the right triangular ligament, which is also divided. And then with the right hemiliver mobilized, you can see here, so the Laennec capsule and how it is open in order to encircle with a tape the right hepatic vein. Then we continue isolating the middle hepatic vein, which was independent from the left hepatic vein. And this is the caudate lobe and the beginning of the dissection. Again, you can see the Laennec capsule, which is detached from the hepatic vein in order to have the dissection plane. Usually we use this water jet dissector, which works mostly similar as the CUSA. Again, as the tumor was very close to the main hepatic veins, we clamped firstly the pedicle and then the right hepatic vein. This clamping, we maintain 15 minutes of clamping and 5 minutes of declamping in several periods. And you can see how the vein is severed from the liver parenchyma. And you can see even with a window in the vein, there is not blood because of the clamping. the Gleasonian pedicle is dissected, and here we had to remove a patch of the vein because it was really very attached to the tumor. So we put a clamp, a lateral clamp, in order to resect a patch of the right hepatic vein together with the tumor. And you can see then the surface of the tumor that it was in contact with the middle hepatic vein, which can be seen in the deep of the resection. Also with in the plane of the Laennec capsule, in order to be as radical as possible. Tiny veins are ligated and divided. We continued with the harmonic scissors, and here the spigal lobe, the paracaval part of the coated lobe and the coated process. A running suture was performed in the right hepatic vein. And after that, we declamped. Here you can see then the right hepatic vein, the middle hepatic vein in the bottom, the inferior vena cava, and the other side also the resection of the spigal lobe. So in conclusion, the importance of the Laennec capsule as a dissecting plane for cranial approach to hepatic veins must be stressed, mostly for tumors close to the hepatic veins. The cranial approach to hepatic veins combined with selective vascular occlusion is safe and reduces risk of bleeding. And the dissecting plane along the Laennec capsules allows an oncological appropriate R1 vascular resection. Thank you very much for your attention.
Guido, first discussant. Guido, please.
I was prepared to discuss your talk, but I didn't expect you were showing R1 vascular. So I cannot say anything because I enjoy a lot your operation. It's exactly what we are doing, and I think that I may say that, in my opinion, the Laennec capsule is not really the key for driving the dissection of the hepatic vein. I consider the Laennec capsule a further protection to justify also oncologically the results of the R1 vascular, because it supports the idea that it is the vessel inside the liver are separated by the parenchyma, like the vena cava. So in reality, if we detach the tumor from the vena cava, we are detaching also the tumor from the hepatic vein, and then R1 vascular is a sort of detachment for a structure that is almost outside the organ, anatomically, and then justify the results. And I am pleased to see that your operation was really, I enjoyed a lot. I would have done a tunnel in this patient, but you suggested another approach. Just a segment, full segment 1 extended to segment 7 a bit. It was very nice. So I agree, it's a nice success, and I suggest you to send it to Anasosurgical Oncology. They will publish the video for sure.
Thank you.
Thank you, Guido. Now open Pietro, please.
Thank you, Oscar. I really liked it. And I would like to ask a question to you and Guido. my impression is that the capsule, the Laennec capsule, in fact gets thickened next to metastasis. There is sort of desmoplastic reaction, and you can profit of that much more close to a tumor than you would in a normal dissection like a living donor.
That's completely true. I agree, Pietro. I don't know, Guido, if you want to say anything.
Oscar.
Also our experience.
I have a question.
And it drives you the best.
I have a question, Oscar. To be clear, the Discussant capsula, in fact, is in continuity with the peritoneum. Indeed, the Discussant capsula is the peritoneum covering the liver. Totally different from the Laennec capsula. And this is clear on the scheme and the drawing of Laennec. But what is interesting is that the sheet entering inside the liver is the one described by Laennec. It's not the Discussant. That means, if you agree, the Discussant pedicle are not Discussant pedicle, they are Laennec pedicle. Do you agree?
Well,
This is on the
what we call Discusonian pedicle is covered, surrounded by the Laennec capsule. It means you have the Discussant sheet, but outside is covered also for the Laennec capsules.
But
so that way is thicker than the other.
On the drawing, the first drawing, the Discussant is not entering the liver. You may see on the drawing of Laennec. Exactly. And that means on the hepatic vein, when the hepatic vein go outside the liver, it is covered by the peritoneum. But inside the liver, there is nothing. They are nude. It is clear on the Discussant, there is nothing around.
Listen. When at the time, please.
Pietro and Oscar.
Yeah, Pietro.
No, Pietro, please.
Give the microphone, please.
In fact, I don't think they are nude inside the liver. I think there is a separate layer between and a separate layer that becomes thicker closer to a tumor that you can profit from when you dissect. When you think that there is one layer on the hepatic vein, no, there are two layers. There is the layer of the hepatic vein and a further layer, and if you pay a lot of attention, like he did, you can detach two layers in the hepatic veins. This is what I found. I mean, I have a picture of that, but I don't know.
I agree with you, Pietro, but what is the name of this layer? It's not Discussant and not Laennec.
It's called the cardiac portion of the Laennec capsule, which is surrounding the inferior vena cava and the hepatic veins. It's a Japanese paper that describes this kind of sheet.
More
You're
questions?
not convinced.
More questions about this fantastic anatomy history? Nobody wants to speak?
Resect a small part of the hepatic vein, so you resect a small part of the hepatic vein. Clamp
Yes.
and resect. Why?
Because it was so attached to the tumor was invading.
I thought that
differently.
R1 resection is possible. So why did you do that? If
Because
you are
it was
sure that there is two layers between
Yes,
the hepatic vein and the tumor.
Case, and Guido could tell better than me, that sometimes you have to resect a patch of the vein.
Was it
You
invaded
saw
in
that
the
in the
in
middle
pathology?
hepatic vein
Was it invaded in pathology?
No.
Okay, thank you.
Happy, eh?
Was not
invaded, huh?
necessary. So
Fantastic.
you're right. Oh, okay.
You
Go on.
want to comment also this, please?
I mean, it is not a failure of the R1 vascular if you resect partially a part of the hepatic vein. In our series, it happens often. But first of all, he did a double-sided R1 vascular The middle hepatic vein was detached, so this was a full R1 vascular. This is a partial R1 vascular. At a certain point, you don't have to demonstrate anything. If you cannot detach it, it becomes risky. Resecting part of the vein is the advantage of the hepatic vein that gives also the mid solution, no? You can also resect partially, and most of the time you don't need the patch, so as you did.
No, it was running suture.
We have patched twice. So I think there is no contradiction. R1 vascular is possible when there is not infiltration, just contact. So this is the if you add it. Most of the time, you have the chance to, for the hepatic vein, most of the time. It's very rare. When it is unsuitable, most of the time, it is because the contact is so tight and so large that you may expect that there would be the sacrifice of the vein, and they have the collaterals, because the liver adapted to this stricture. In example, according to, it's not my experience, but it's also my experience of 20 years in Italy, but this was the one of Macucci previously. He never substituted the inferior vena cava, never. I can show you the picture, and we did the same. You just have to take time, but most of the time you do, like the hepatic vein, a partial resection.
I believe you.
No,
Just a question.
I have the picture. So.
Is the size of the metastasis influence in your technique? I mean, that is perfectly understandable for small metastasis, but for large one, with a large contact, you know, a relationship with the hepatic vein, do you still do that, or the size is important for you? No?
Paradoxically, we do the resection, the partial resection, when there is a big metastasis that has been shrinked after chemo, and the relationship with the vessel becomes tight for inflammatory reaction, and then with a tiny lesion like this, you cannot detach the tiny lesion. While naive metastasis, it was the experience before that we didn't do the neoadjuvant, even large, just compressing, most 95% they can't be detached. They just push the tumor, the large metastasis.
Okay.
Are you convinced?
No, probably not.
Okay.
Of course I am.
Yeah. Yes. Nobody wants. You want to comment? No. Eduardo, nobody. Antonio, no. Okay.
Well, thank you. Thank you very much.
So may I call Fabio Procopio and Catherine Tett for the discussion?
Catherine is not here, I think.
Is not here? No. Some others.
There is no more discussant.
So,
Okay. I'm honored to be here. Thank you very much for the possibility to share my paper, and thank you, Professor Bismuth, and thank you, my mentor, Professor Torzilli. I'm talking about the application of the compression technique for anatomical liver resection in minimally access liver surgery. In resective fields, as well known, the anatomical liver resection is the best oncological treatment for hepatocellular carcinoma. The first suitable solution for defining liver segment in anatomical fashion has been proposed by Macucci with the dye injection technique. These techniques, more recently, has benefited by the ICG introduction, obtaining or positive staining area by direct injection of the ICG in the portal pedicle, or the negative staining one when we clamp before the portal feeding the tumor, and then the ICG is injected by intravenously. But the problem is this technique has the same drawbacks related to the dye injection technique because we have no negligible rate of unsatisfactory staining area. So another solution, as the technique proposed by Takasaki, the so-called Gleasonian pedicle approach, and we know it is very technically demanding and is associated to high risk to biliary vascular injuries. The evolution and the alternative was the technique proposed my mentor, Professor Torzilli, the so-called compression technique, consisting in the finger compression of the pedicle field in the tumor, obtaining a transit ischemic area is easily to be detected and demarcated by electrocautery. More recently, we implemented this procedure injected by ICG. This is a procedure we compress with the finger the pedicle feeding in the tumor, and we had that ischemic area. And then under the compression, the ICG is injected by intravenously by the anesthesiologist. In this case, the resection area become like no stain is more clearly to evident on the liver surface. This is the compression. We can see the pedicle before and under compression. We can see the resection area. Under the compression, the anesthesiologist injects intravenously the ICG, and the anatomical area become more clear and can be demarcated by electrocautery by the first assistant. And this is the resection area, and this is the cast surface with exposure of a right hepatic vein. In a minimally invasive surgery, of course, the anatomical liver resection is a very challenging procedure. The most common procedure is the Gleasonian approach, but as well reported, is a high risk of vascular biliary injury. Otherwise, another technique is the injection technique with the same limitation of the puncture techniques, but we have higher complexity related to the minimally invasive setting. So, another approach is the hepatic vein approach. Is an effective technique, but is related to high risk of uncontrolled bleeding for pull-up injury to the veins or for direct injury on the vessels. So now we try, on the basis of our experience on the compression techniques, we try to transfer the techniques from open to minimally invasive approach. So we start with our preliminary experience. We included patients with very non-located tumors, peripheral lesion, and with just one tumor-feeding pedicle visible at the preoperative imaging, and we exclude patients with the vascular thrombosis and deep located tumors. And we start with the laparoscopic approach to become more confident to the procedure because we have the tactile feedback, and then we transfer the technique also in robotic approach, as this is a tumor location in our experience and post-placement. And we start with the laparoscopic approach. Like in open surgery, we start with the left side lesions. This is the first case with the lesion located in segment 2. We can see the pedicle before under clamping. We have the probe one surface and the opposite side with the grasper. This is the fluorescence images with the ICG injection, and then we can see no area that is demarcated, and this is the cut surface with the stamp of the pedicle for segment 2. This is another case, is a segment 3 segmentectomy, is here ultrasound image with the compression before and under compression, and the under compression performed by the first operator, the first assistant, demarcate the resection area is clearly evident like a non-stained one, and below we can see the resection area and the stamp of the pedicle for segment 3, and then this is part of the left hepatic vein. After that, we try to adapt the same technique for right side lesion. This is a case of a lesion located in segment 5. And then we explore also the feasibility on the posterior superior lesions. This is a case of ACC located in segment 7. This is a 3D vertical cast with the resection area, tumor location, and the pedicle to be compressed. Now this is the compression. The patient has a chronic steatohepatitis, so we can see the discoloration of the liver. And under compression, the ICG was intravenously injected. And then anatomical area of the segment 7 was clear, evident, like a non-stained area. And during the first surgeon compress the liver, the first assistant with the electrocautery demarcated the area on the liver surface. This is the pedicle compressor before, and this, we can see the right hepatic vein exposed on the cut surface. And then we transfer also in a robotic approach. We started the robotic program last year. This is a case of a huge ACC located in segment 7. This is a virtual cast with the right hepatic vein, with the compression point and the lesion in segment 7. This is intraparietal ultrasound. We can see the pedicle is compressed by his robotic instruments. And under the compression, in this case, the first operator can be done everything because we have 3 arms. This is the demarcation, and we can see the discoloration area here. The lesion is here. Is clearly evident on the liver surface. This is the final resection area, and this is the pedicle for segment 7. And here on the right, we can see the right hepatic vein fully exposed on the cut surface, meaning an anatomical resection of segment 7. So our results. We include the 13 patients. The procedure failed in just 2 patients, both in laparoscopic and robotic approach, both for a lesion located in segment 7, probably because the pedicle was too deep to be compressed in an effective manner. This is the surgical procedure in details, 6 laparoscopic procedure and 5 robotic procedure. All procedures were air margin, 0, no complication, no conversion, and no relapse and local recurrence after median 30 months. So in conclusion, the ICG compression technique is safe for performing anatomical liver resection in the oncologic and adequate. This preliminary experience shows an encouraging applicability on ICG compression in laparoscopic and robotic setting. Of course, we hope for the study are needed to investigate its applicability and to standardize the procedure. Thank you very much for the attention.
So there is an open discussion. Nobody wants? No.
That was a terrific presentation. I just wonder, a small technical question about the increased difficulty in patients with more fibrotic or cirrhotic livers, and how well you're able to achieve that same compression, or is it not an issue?
I don't understand. Please, can you repeat, please, the question? The compression of the liver?
In patients with more fibrotic or cirrhotic livers, do you find that there are limitations to the ability to compress like you're describing, or is it technically not too difficult or different?
No, it's not so difficult to compress the liver. So, of course, the effective of the procedure depends on the stiffness or of the liver, but sometimes it can be a selection criteria for anatomical and non-anatomical liver resection, because if the liver is too hard, probably is not indicating anatomical resection, so we can plan an enucleation or a partial resection of the ACC.
So technically makes it more difficult then?
Yeah. Okay. Is reversible, is not invasive. I suggest to start in open surgery to be confident in a procedure and then to transfer to in a minimal invasive setting. But I think it's not dangerous or not particularly difficult.
Thank you.
Thank you very much for the question.
So, any other question? Thank you very much.
Thank you, thank you.
Pardon. Okay, now I would like, for the young people are not compagnons, you can talk also. It will be nice to have a question from you also. Please be interested. This is a meeting, open meeting. Giuseppe Torre, please come. Role of surgery in patients waiting transplants for HCC.
Thank you very much. Merci beaucoup, Monsieur Bismuth. Thank you very much, Guido, for the kind invitation. I also am not compagnon, but I'm the guest. So I have to speak the role of surgeon patient waiting list for transplantation. I want to thank, first of all, Guido that participated to this publication in Springer, Italian publication concerning ACC. Treatment of ACC during old or before old is a challenge because considering downstaging procedure and the treatment of ACC during the waiting list. So surgery in potential candidate for transplantation, there are some concepts to stress: selection tool, bridge transplantation, salvage strategy, downstaging strategy. And there are some technical key points in candidate for transplantation. The surgery can avoid prolonged pringle clampage, avoid, when it's possible, cholecystectomy, avoid open surgery when possible, avoid hemostatic agents, avoid inferior vena cava exposure, early drain ablation if it's possible, anterior resection cause some major visceral adherence. So minimal invasive approach is more demanding for some reason: no porto-systemic shunt interruption, no large liver mobilization, no contact with atmospheric area. For example, this is a resection of an anterior approach segment of the liver, segment 4. This is a good indication before transplantation, like downstaging or like bridge procedure. But the problem is this is an anterior segment. At the time of transplantation, you can find many adhesions of this segment with the surrounding tissue, duodenal, stomach, colon, and the transplantation may become difficult to perform. And Olivier Subran showed also that the adhesion, when you perform the laparoscopic or minimally invasive approach, can be, we have to promote the minimally invasive approach to reduce adhesion. Also, the surgery move to child pag B cirrhosis. This is a multicentric study. And also, Guido showed that we can treat patient child Chi with surgery also before transplantation. For selection tool, we have to consider that some G3 patient may have a high risk of recurrence after all, so we operate after we have to decide quickly what to do, or quickly to surgery, to transplantation, or is not good to propose transplantation with this patient. This is a patient with a G3 little ACC that we operate, and after we have to decide if to transplant or not this patient. This is a little laparoscopic ablation of this tumor. Bridge is a concept really important because from the beginning of the waiting list to transplantation, the ACC growth, there are many treatments, TACE, ethanol injection, radiofrequency ablation, liver resection, or radioembolization. Every tumor board have the policy, flow chart. We have our flow chart in Rome. That concern from the experience of the center of the guideline of the society. This is a resection of a patient that was resected of the left lobe, an ACC of the left lobe, and recurrence in segment 8. And we decide to treat this patient with transplantation also of the tumor of the right lobe. And you can show that there are many adhesions, even if it was treated of minimal invasive approach of the left lobe. The cirrhotic liver, we mobilize the liver and we remove the the tumor of the posterior segment. The problem was that it was portal hypertension, but with a robotic approach, we could control the porto-caval shunt that you can show in this film, and this device can control this shunt and coagulate this shunt without major problem. Shunt between the liver and the diaphragm, between the liver and the tissue around the right lobe. And the salva strategy is also an important concept because there is operate the patient, waiting the recurrence, after the recurrence decide. At the beginning of the 2000, there was a querelle in Paris between the two important equipes with the strategy of this patient, which kind of treatment was the best, but the René Adam with this study and Monsieur Bismuth show, and I agree with him that the transplantation is the best treatment of this patient. And I remember when Professor Bismuth came in Rome and showed me that the patient in this study is different of the patient in the other study. I show a picture and explain in my bureau this conclusion. And we are not too much liver to transplant, so more and more we utilize resection before transplantation. And we are our experience in Italy of the transplant salvage transplantation. This case was a patient that was first submitted to the left lobe resection for ACC, ethanol intake of calculs was not possible to transplant at the time of the first ACC, and so we decided to resect the left lobe and wait after 2 years of observation, recurrence on the right lobe, and we arrived to transplantation. You can show that at the moment of transplantation, there are no major adhesion between the liver and the surrounding tissue. And the last point is the downstaging strategy. And we all know that the Milano criteria is possible to go in this criteria, but the BCLC tried to move on the left side to put the intermediate stage and advanced stage in transplantation. So we utilize many instruments to reduce the disease, the FCC. So this trial of Mazzaferro showed this is the good results of downstage patients that go to transplantation. And also, this is a case of a patient with a disease on the right lobe and left lobe. Then we decide to control with minimal invasive approach on the left lobe and radioembolization on the right lobe. The alpha fetoprotein that was at the beginnings of more than 1,000 arrived to 45 at least in the moment of transplantation. And so this is our strategy of downstaging with many times that utilize radioembolization with E390. Also the ALPS we consider before transplantation, in our case of 42 cases of patients with huge ACC that arrived to be resected with good results in the post-operative field. And this patient many times have macrovascular invasion, and we have a surprise that one patient, even if the volume future liver remnant was okay, developed a post-operative liver failure. Post-operative liver failure is a very difficult to treat, and we tried to put auxiliary transplantation in this case. You can show on the left part the remnant left liver after ALPS, and on the right part a little graft to try to reduce, to control this disease. So also the last slide is this. I want to thank Vincenzo Mazzaferro for this study that tried to prioritize the patient according to the treatment that received this patient. In conclusion, surgery in liver transplantation setting is more demanding, can be considered before listing, during waiting list period, or as a downstaging scenario. Surgery can be associated with other intervention procedure of bridging, downstaging with encouraging results. Surgery have to be considered more and more laparoscopic or robotic. Thank you.
Thank you for discussing this paper. Is Hugo Pinto Marques.
Thank you very much for this nice presentation. As you know, of course, the problem of organ shortage is one of the things that make us have this discussion and think about using resection, for example, as a bridge to transplantation. One of the things I wanted to ask is actually, we know we had a lot of polemics, especially about resection and transplantation, when we compare the results of the Paul Bruce and the Bourgeon group. This is an ancient discussion, and we know at that time that one of the reasons between the different results of the two groups, one of them was methodological and about inclusion of patients in the transplantation group, whether legitimately or not, and the other one was the percentage of minimally invasive patients in the HCC resection group before transplantation that apparently led to better results. So my first question is if you think that the fact that we are doing more and more minimally invasive resection is influencing the results toward better results after transplantation. And the second thing is a provocation. I think if you use ALPS for resection, you are going to induce much more adhesions in a liver transplantation. Do you think this is going to worsen the results or not? Thank you.
Thank you, Hugo, for the two questions. The first one with minimally invasive approach, I agree with you that the paradigm change with minimally invasive approach on the ACC actually, because the transplantation more easy. And you observe that, well, in our 42 patients that have ALPS, only one was scheduled for transplantation, because I agree with you, many adhesions, pedicule difficult to dissect, and so I agree is a frontier of this surgery.
Okay, I'm going to open Sylvia, please.
Congrats on your presentation. I'm Sylvia from Lisbon. We are actually doing more and more resections of HCC in cirrhotic patients by robotic approach. And we have seen that with the robotic approach, we have less ascites in post-op than in open approach. Do you have the same experience? And do you know why this happened? It's because the mobilization, it's because we perform more Pringle maneuver actually with the robotic surgery, but we have less dysfunction in post-op.
Yes, I agree with you. You observe this concept was stressed by Gianmauro Berardi when shown with the Japanese in the study of child B patient treated. And I agree, less liver mobilization, less portocaval shunt interrupted, maybe less pedicule Pringle maneuver, many factors that the results of ascites are much better. ACC, but also in liver mets, in all the laparoscopic surgery, not only in the liver, also in the colonic and on the other pathology.
Especially in cirrhotic livers.
Especially in cirrhotic, of course, of course. Mobilization, portocaval shunt, and many things. Thank you.
Another question.
Yeah?
It's about downstaging. Now we have more and more drugs like atezolizumab Do you think that atezo-bev will bring more patients to resection than to other kind of unstable local therapy like chemoembolization or microwaves?
I think yes, but not alone. I think atezo-bev and other immunotherapy, not alone, but combined with radioembolization or chemoembolization, radioembolization in particular. Really strong procedure that is not demonstrated, but maybe that atezo-bev or the immunotherapy are more with good results in patients that perform before radioembolization.
Yes. Eduardo, please.
Very nice, your lecture. I enjoyed it very much, very complete. My question is, which is your opinion about radiofrequency in the cases that is indicated to maintain this patient active in waiting list?
That's a good question. We don't know radiofrequency for a polysurgical procedure, and our radiologists perform radioembolization with the recurrence of DCC in the posterior segment difficult, so we utilize radioembolization, radioablation more and more. And also radioablation have some improvement in the last year, difficult need. So yes, we utilize, but is in the radiology unit, not in the block.
No questions from the more... please, René.
Just congratulations. Just a comment concerning the debate about resection transplantation. I will not go deeper in this debate, but it seems to me very important for the message we give to our patient. What we know is that, of course, transplantation is doing much better on the long term, disease-free survival, and so on. But anyway, what the message we give most often to our patient is, don't worry, we resect your tumor, and if you recur, we will transplant. But what we know factually is that in 50% of the case, this will not be possible. And so our message should be a little bit different, with a nuance, to say to the patient, we are obliged to resect you because we have no sufficient donor to transplant you, but know that it is not 100% the opportunity to transplant you in case of recurrence. And in the case of possibility of living donor transplantation, this may change a little bit the opinion of the patient and of the family. And so we should be honest in the message we give to our patient. I don't know if you agree on this.
Thank you, René, for this question. Is my policy in Rome last year, I performed 70 liver transplantation, no huge number, but important number. When it's possible, I resect, and I don't speak of transplantation at the first line. When there is the recurrence, when there is decompensated cirrhosis, I move to transplantation, because I agree with you, it's not honest to propose liver resection when transplantation has better results. And so I don't propose like first line, because I can't.
Okay, just a moment. Riccardo, please. And after, okay, please, Valerio.
It's the same kind of reflection, more ethical reflection. The problem is that we share all the same organs, and if every centers don't do the same, there's a problem, because we have the same policy of salvage transplantation, so we operate those patients, but if our neighbors, transplant centers, don't operate the patients and they list systematically all the patients, there is inequality of treatment offered to our patients. So our patients that we operate, because we think that for the population it's better, for the patient, of course, it's not better. For the patient, it's better to be transplanted. So there is an inequality. So there should be probably a political decision or a general decision that everybody does the same.
I agree with you. This is a political decision, not surgical decision. Everybody know the different Établissement Français de Grefte and Italian Center of Transplantation. They have to correct, to change this history, I think.
What do you think? Congratulations on your presentation. What do you think about resection as a tool to select patients to direct transplantation? We analyzed our series and we applied several classification systems in high risk and low risk. We became with a classification that give our patients high risk 13% 5-year overall survival and not, low risk 98% of survival. What we are doing now is applying after resection and applying the classification, we are transplanting upfront the patients with high risk and we are monitoring the patients with low risk. There are already groups like Lisbon who go doing the genetic panel, we are doing the immunological one, and we are trying to figure before resecting the patients is to know what are the patients that are going to benefit more with a transplant and the patients that will go well with the resection. What do you think about it?
I think that when we try to resect this patient to have the specimen to decide if it's aggressive, not aggressive, satellite node, G-trap patient. In this patient, we have not proposed quickly a transplantation, but radioembolization to control the disease. We speak in the meeting with the pathologists, some drug, immunologic or atezobeva in this category of the patient. And we observe test of time, and after we decide if can we do a transplantation or not candidate for transplantation.
So you are not doing upfront liver transplantation after resection?
No.
Okay.
More questions from the Professor Bismuth.
Often, HCC in cirrhotic patient, there are two diseases. One is the tumor, two is the cirrhotic patient. Resection treat only one. And transplantation both. Unfortunately, we cannot offer transplantation to all patients with HCC. And I may say also, unfortunately, HCC on child A cirrhotic, you do resection. And you give the better treatment of HCC in child B or C.
This is a reflection. We finished with this. Do you want to comment this?
No, this is
Thank you, Professor Ettore.
Honored comment.
Okay. I think that Professor Dong is not coming, but I would like to, Guido, I decided to say thank you very much for organizing this meeting at the end of the session and not at the beginning. And it's a pleasure to be here. And thank you very much for organizing this fantastic meeting. So, what you are going to do, Professor Dong, are you doing this? No, Dong is not coming.
Okay. We tried to contact him since yesterday night and send the link for give the presentation, but he never answered. So
not in prison? No.
I don't think so, but I don't know which was the emergency meeting that he had with the government. You know, in China, you may never know what is going on.
What's a joke? That's a responsibility for
so
me.
Nowadays, we anticipate the lunch break, and probably we could also anticipate the beginning of the session and finish earlier.
Sorry?
And I would like to ask to all the Compagnons to confirm their presence tonight to the secretary, not to me, to secretary. Because if you confirm to me, it will be a disaster for you. I will forget for sure the names and whatever. Sorry.
So Guido, you can begin the session 2 o'clock. What do you think? Anticipate 35 minutes the afternoon session.
Yeah.
Okay, we
It
begin at
depends
2 o'clock.
He will decide.
After lunch.
Professor Bismuth will decide.
Professor Bismuth?
Will decide.
Professor Bismuth have already decided that we begin at 2 o'clock afternoon.